Good afternoon, respected chairpersons and my dear friends. My talk would be on the current trends in the management of spinal tuberculosis. We all know that spinal tuberculosis is one of the commonest diseases which we see in the Indian subcontinent. Unfortunately, India accounts for a quarter of the world's annual incidence of spinal tuberculosis. We do know for the fact that tuberculosis is a curable and a preventable condition, and uncomplicated spinal tuberculosis is a medical disease. Adequate treatment curtails onward transmission of the infection, but there is a gracing concern in the increasing incidence of drug-resistant tuberculosis. Where are we today with respect to tuberculosis? If you look at the WHO NTB strategy, we are lagging way behind in reducing the incidence of tuberculosis, the number of TB deaths, and the percentage of the people who are affected with the tuberculosis and facing a significant amount of costs. What about the investigations in concerns with patients with spinal tuberculosis? The question is what to do. If you look at the most common investigations, what we need to do is to look at the general condition of the patient, HBT, CDC, ESR. ESR is prognostic. We have to look at the HIV tuberculosis syndemic, RBS, blood sugar has to be well under control, LFT as a monitoring, because most of the anti-TB drugs have hepatotoxic side effects. What not to do is basically also important. We do know that the blood-based PCR test, the antibody tests are no longer useful. And even the TB Gold test and the MAN2 test is basically useful in diagnosing latent tuberculosis. And in an endemic country like India, it may not be of a major significant usage. By investigations, MRI still remains the gold standard. And probably we should be able to come to some degree of diagnosis with the use of MRI to a large extent, especially when you have a well-defined paraspinal abscess, which is extending along 2 or 3 levels. The abscess wall is very thin, and then it goes in more in favor of tuberculosis. If there is a subligamental spread of 2 or 3 multiple bodies, multiple skip lesions, a thoracic spine involvement also goes in favor of spinal tuberculosis. We have to understand that even then, a classical paradiscal in a thoracic with a thin cold abscess may be ideal, but tuberculosis is a great mimicker. Therefore, we need to do a biopsy for all these patients to confirm it's tuberculosis, because it could be a pyogenic, eosinophilic granuloma, lymphoma, any one of these disorders or many more disorders can mimic tuberculosis. Therefore, it's important to have a diagnosis. Therefore, is it always important that we have to do a biopsy? Yes. But in the lesions which are early with no destruction, probably we can get away by doing a biopsy and treating the patients with anti-chemotherapy. However, in patients who present with neurological deficit with instability, it's safer to do the combined procedure together, the surgery and biopsy at the same time. When you do a biopsy, it's important that we send the tissue always for gene expert, TB culture, histopathology, and pyogenic bacterial culture. And in certain situations, you may have to send for fungal culture also. Traditional smear may not be of much use in patients with spinal tuberculosis. We know that the spinal TB is basically a possibocillary condition and not an ideal scenario. Where do you take the biopsy from? Ideally from the lesion, image guided and CT guided. Transpedicular is much more easier. You can aspirate the cold abscess whenever the cold abscess is easily accessible for you. There are various terminologies that has come into place. The presumptive, that is based on the clinical features you suspect is tuberculosis. You do a biopsy or a bacteriologically confirm it's tuberculosis is a confirmed case. Whereas when you send it for tissue diagnosis, but it comes as negatives. Clinically, they are thought to be tuberculosis. But when you look at the negative microbiological culture, it is not very favorable. It gives a non-specific spondylodiscitis. Even then, if the MRI is very conclusive, it's okay to start on anti-tuberculosis drug, a trial of conservative treatment. If the patient is responding, then we can presume that it is tuberculosis and continue the same. And we also know, again, in drug resistance, it could be clinically diagnosed or bacterially confirmed treatment failure. But we have to understand that tuberculosis, especially a drug resistant, when you do the biopsy again, you may not get a culture positivity rate, which is as low as sometimes 30 to 60%. Therefore, most of the time, the drug resistance would be diagnosed more based on a clinical rather than on a bacteriological confirmed methods. We know the other recent change that has happened, the tuberculosis is a notifiable disease, and the chemotherapy is right now advocated for up to a period of 1 month, 1 year. And the other important change that has happened is that in the continuation phase, ethambutol has to be continued for the next 10 months' time. And it's important, the most important aspect of tuberculosis is monitoring. We have to look for ESR, LFT, and weight gain, a sense of well-being, which implies that the disease is healing. You look for various clinical signs, the weight gain, laboratory, the ESR, imaging, X-ray, MRI, and PET scan also could be used. I do not use PET scan in my practice to look at healing. Most of the time is clinical assessment and sometimes supplemented by MRI in certain group of patients. But the most important thing of drug therapy is to prevent failure. And the most important aspect, I would like to put it as counseling, 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 and counseling again. Give the body weight based drug dosage, patient to compliance, nutrition, vitamin D, and vitamin C. I would like to emphasize again that this is the most important aspect. If you look at drug-resistant tuberculosis incidence in southern part of India, it's about 5%, whereas in India, in the northern part of India, including even Mumbai, the reported incidence could be as high as 15 to 20%, which is actually not acceptable. And probably we have to play a very important role in decreasing the incidence of drug therapy. A word about paradoxical reaction, wherein the patient who is on anti-TB drugs, who's feeling better, initially shows improvement, suddenly starts deteriorating. It's just an immune response. You continue the same line of therapy. This is as against drug resistance where there is no improvement at all. Therefore, we know now that the uncompleted spinal tuberculosis is a medical disease, whereas the presence of complications like deformity, instability, or significant neurological deficit is a different ball game. And you need to, this is what is called as complicated tuberculosis. Therefore, in complicated spinal tuberculosis, whenever there is a neurological deficit, severe vertebral infection like panvertebral disease, the presence of spinal stress signs, a kyphotic deformity greater than 30 degrees, instability, they are all indications for surgery. One of the new recent developments that is likely to come within this year is probably the defining what is tuberculosis, what is instability in spinal tuberculosis. There is work going on by two different authors group, and probably within the next 6 months to 1 year, we will have a definitive idea what do you mean by instability in spinal tuberculosis. What about the elderly? Elderly, even though they are patients with high comorbidities, we have found that the results are good, and if indicated, you operate them early, make them ambulatory, the outcome is much, much better. We do know that the risk factor for severe progression is age less than 10 years, vertebral body loss, pre-treatment deformity of greater than 30 degrees, junctional levels, and the presence of spinal stress signs. Now we know which surgery to do, when do you have to do surgery, but which surgery to do, whether to go from anterior, posterior, or a combined approach. These are the goals of surgical treatment: decompression, deformity correction, and stability. The question comes whether it's necessary to do all the three components. Most of the time, it could be adequate to do one or two of these components. And in some scenarios where you may have to look at deformity correction, because deformity in active spinal tuberculosis is largely flexible and it can be corrected by your positioning and minor degree of compression during the procedure per se. Therefore, when you choose approach, the Hong Kong procedure and the modified Hong Kong are the one which have been traditionally very popular, still popular in case of anterior disease, in case of cervical spine. Whereas in Hong Kong, you remove the whole of the involved vertebra, whereas in modified Hong Kong, you just remove the part of the diseased vertebra so that your segment of fusion becomes significantly lesser. Chances of graft failure also becomes lesser. It is still the mainstay of treatment in cervical tuberculosis. Rarely you do nowadays due to a combined antero-posterior approach because the posterior surgery has advanced to a large degree. It has obviated the need of this approach. Therefore, now the current trend is for mainly all posterior approaches, especially in thoracic and the lumbar spine, where you can achieve all of this. We can achieve decompression, debridement, reconstruction, instrumentation, correction of deformity, all by a posterior approach, what is called as the global fusion. Therefore, posterior surgery could be just an instrumentation. You can instrument with decompression, you can transpedicularly debride, and you can do a global reconstructions. So these are examples of a posterior only surgery, wherein it is instrumented with a good degree of correction. And basically what happens, as I mentioned earlier, it's a flexible disease. Tuberculosis of active spine is a flexible disease. Moment you position the patient prone, you instrument, compress it, usually it heals with a good consolidation. And even at 6 months, it could be adequate, especially more so in the early tubercular lesions. And is ideal in patients with a posterior segment disease, that is tuberculosis involving two adjacent vertebral segment is basically what is called as a posterior segment disease. You can go much shorter alone. Therefore, most of the scenarios in thoracic and thoracolumbar tuberculosis are lumbar tuberculosis when the vertebral body involvement is less than 2 or 3 vertebral bodies, because when it becomes more, it becomes difficult to reconstruction from behind. When the overall vertebral body loss is less than 1, elderly patients with severe pain, multi-level involvement, a posterior surgery alone is adequate. When the vertebral body loss is more, when the defect is there, you've got two options. One is to do a posterior laminectomy and just shorten the posterior column or to reconstruct. This is an example of a transpedicular debridement and posterior closing wedge osteotomy, a good correction of the deformity, a good healing of the lesion. And this is what we do because the anterior lesion is soft, you need not reconstruct. But if there is a deformity, you can reconstruct the anterior column like a till. If a transfemoral excision, facetal, resect it, put a cage and come out. And we have moved to do that same in the thoracic spine. I mean, the introduction of a TLIF cage is easier. We can have different custom-made cages up to 20 millimeters. Thoracic vertebral bodies are lesser. You may have to remove the rib and you can achieve a good degree of correction. But when the defect is more, you may have to use a cage to reconstruct, and you may have to remove what is called as a costotransversectomy or an anterolateral approach, which helps in the reconstruction. A pictorial representation of an operative procedure where a transfacetal reconstruction with the cage. And it could become more difficult as you come down to the thoracic spine, but in the lumbar segment, it's important to save the motion segment. Use the part of the pedicle which is not affected, use it as a part of your fixation anchor points so that you can reduce your fixation to monosegmental or sometimes involving one more vertebra. But in this scenario, save the joints and you can remove the implant at the unfused segment once the disease tends to heal. We know that now the disease cure is not everything in spinal tuberculosis, because in children, the disease tend to progress. As a classical example of one of the MRC study patients, disease progress over 6 years to a horrendous 128-degree curve. Therefore, it's important in spinal tuberculosis, identify which is uncomplicated or complicated. Uncomplicated, treat it medically, do a biopsy in most of the scenario. Most important thing, ensure compliance, adequate drug dosage based on the body weight. Surgery is indicated only in patients with neurological deficit and instability. If surgery is indicated, we can go for a simple procedures like posterior-only instrumentation to reconstructions. Anterior surgery is definitely the treatment of choice when you indicate surgery in cervical tuberculosis. Thank you very much.